Hello, hello. Yeah, hi, good evening, everyone. Can you just give me a quick thumbs up whether my audio and video is fine for all of you? जल्दी से एक thumbs up दे दो so that we can start. Okay, yes. Chalo. So, welcome to this one-shot radiology program specifically designed for foreign medical graduate screening exam. So, I will not take much of your time, and our exam is less than a month away. So, I'm just gonna take you through some very quick questions that are must know from radiology, and you can say that they will be a cakewalk for you in the exam, right? Yeah, hello, Dr. Ashwani. Now your session is success if Dr. Ashwani is watching it. Eh? Yeah, so I will provide the annotated PDF. Bache, Simran, let me just see how to give it, or otherwise I'm gonna share it on my Telegram channel at Rajat Radiology Review. Okay, chalo. So, देखो, without wasting much of our time, let us start. And these are the basic questions that we are expecting in the FMG screening exam from the radiology. So 1 to 2 questions will be on identification of the name of the investigation. 2 to 4 questions on diagnosis, which is based on an image. One question will be from nuclear scan. 1 to 2 questions from radiotherapy. 2 questions on preferred radiological investigation, and 3 to 5 questions on a radiological image with a management of patient. Now, this is the common scenario. On an average, 12 to 15 questions are there in our FMG screening exam, and I feel that they should be cakewalk for you. Thank you, Avinash. These are the common topics which are asked in the exam. Chest X-rays, you must know. IVP, barium studies, PET scan, ERCP, MRCP, MCU, RGU, HSG, table of radiosensitivity, shape of vertebrae, shape of heart, shape of skull, head trauma, stroke, aortic dissection, pulmonary embolism, pulmonary edema, pneumoperitoneum, intestinal obstruction, intussusception, abdominal trauma, angst and pregnancy. These are the topics that I will be covering in this session, right? So the very important point that I want everybody to remember is this, that the investigations in the radiology are of two types, ionizing and non-ionizing. Now, amongst the non-ionizing, the two that we need to remember are MRI and ultrasound. MRI and ultrasound are the only two radiological investigation that will not give any ionizing radiation. Rest all investigations are gonna give ionizing radiation. Now, in the ionizing, there are certain which uses gamma rays and there are certain which uses X-rays. Those which uses X-rays, these are called as radiological scan, and those which uses gamma rays, these are called as nuclear scan. Now, what are the examples of the investigation that are nuclear scan? PET, SPECT, DTPA, DMSA, MAG3. You should know that where are they used. So PET scan is for glucose metabolism. Now, PET scan is for glucose metabolism. DTPA is for GFR. DMSA is for scar in the kidney. MAC3 is for renal function. It is for renal function. Correct. MIBG scan is for pheochromocytoma. Whereas system scan is for parathyroid adenoma. In our FMG screening exam, the commonest nuclear scan that is asked is a system scan, right? HIDA scan is for biliary atresia. Okay, bone scan is for osteoblastic activity, right? Octodie scan is for neuroendocrine tumor. Selenium methionine scan is for pancreatic imaging. Thallium Helium scan is for myocardial viability. It is for myocardial viability, and Muga scan is for ventricular function, right? It is for ventricular functions. These are the important nuclear scan that you should be aware of, right? Okay. Now, how to decide an investigation? This is one of my favorite slide, and I want everybody to remember this, that how to choose any radiological investigation. Always remember that if you are looking at a bone and you want to see the thick peripheral part of the bone, which is called as cortex. So C for cortex, C for CT. Cortical part of the bone is better seen on CT. The central spongy part of the bone, which is called as marrow, M for marrow, M for MRI. So cortical bone is best seen on CT, marrow is best seen on MRI. If you want to see air anywhere in the body, if you want to see acute hematoma in brain, if you want to see calculi or calcification, CT is the preferred investigation. If you want to see neural tissue, ligaments, tendons, cartilage, the best investigation is MRI. And if you want to see fluid, the preferred investigation is ultrasound, right? So this is a very, very useful point. You look at the disease, that which tissue you want to see, and this flowchart or this slide is definitely gonna help you. Now let us straight away move to the investigation. And the first investigation that we could see is a chest X-ray. Now always remember that in your life, whenever you're gonna see an X-ray, you will realize that there are three colors that you're gonna see. Now these three colors are black, white and grayish. Anything that is black on X-ray has to be air. Remember, anything that is black on the X-ray has to be air. If it is white, it is either bone or stone. Either bone or stone. If it is anatomical in location, it is bone. If it is non-anatomical in location, then it is stone. If it is anatomical in location, then it is bone. If it is non-anatomical in location, then it is stone. If it is present in the lumen, it is calculus. If it is present in the tissue, then it is calcification. Now, if it is in the lumen, it will be round, it will be oval, or it will be taking the shape of the lumen. If it is calcification, it is punctate, it is irregular, and sometime it may be taking the shape of an organ. Always remember this, right? Now let us take an example. Now let us see this. I am seeing a white structure which is taking the shape of a renal pelvis, and because it is taking the shape of a renal pelvis, always remember this is calculus. And what is the name of this calculus? This is a staghorn calculus. On the other hand, this white structure is taking the shape of kidney. If it is taking the shape of the kidney, then this is calcification. And if it is calcification, what is this? This is putty kidney. This is a cemented kidney or a putty kidney, right? Now, all those things are available or valid when you are looking at a plain X-ray. Please remember, if you are looking at a contrast study, now this is a definitely +1 in the FMG screening exam. Don't forget this point that I am telling you right now. If it's a contrast study, the first thing that you're going to ask yourself is, what is the name of the contrast study? Look at the contrast. Is the contrast present in kidney, ureter and bladder? Is it present in kidney, ureter and bladder? And if it is present in the kidney, ureter and bladder, name of the investigation is IVP, right? If the contrast is present in bladder and urethra, can you see the dye in the bladder and urethra? If you're seeing the dye in bladder and urethra, just tell me very quickly, what will be the name of the investigation? What will be the name of the investigation if the dye is present in bladder and urethra? The name of the investigation is MCU, micturating cystourethropy. If the dye is present in only anterior urethra, if it is present only in anterior urethra, the name of the investigation is RGU, retrograde urethropy, right? If the dye is present in uterus, then the name of the investigation is HSG. Then it is HSG. So HSG, RGU, MCU, and IVP. Why it is important? Sorry. If on an IVP image, my apologies, sorry guys. Always remember that two kind of questions are gonna be there in the paper. Question number one, the examiner will ask you what is the name of the investigation. And if the name of the investigation is asked, the image shown will be normal. The image shown will be normal. IVP, MCU, RGU, HSG, or the question will be when a disease will be given. If a disease will be given, the name of the investigation will be given in the question. What is the diagnosis of given IVP? And then you are thinking, on an IVP, if it is this much white, don't think it is stone, don't think it is calcification, it is contrast. It is contrast. And if it's a contrast, the contrast is present in the renal pelvis. That means there is an obstruction here, and that means this is a PUJ block. So never forget this golden rule of imaging, that two kinds of question are gonna be there. Either the question will be identify the image, a normal image will be given to you, or the question will be identify the disease, the name of the investigation will be given in the question, right? Never ever forget this rule. What are the name of these investigation? If you are seeing esophagus, this is barium swallow. If you are seeing stomach and duodenum, the name of the investigation is barium meal, right? Now, there was a googly in this year NEET PG exam. Just be careful that not just the esophagus, even if the neck is given, then it is also barium swallow. Because in a barium swallow, you can see neck as well as the esophagus, right? If you're seeing the small bowel loops, if you're seeing the small bowel loop, then the name of the investigation is barium meal follow through. Right? And if you're seeing the large bowel, if it is large bowel, the name of the investigation is barium enema. Right? Barium enema. So these are very straightforward. Identify the image. Right? Now let us increase the level. Tell me, what is the name of this machine? Which is this machine? So if you see a table and you see a ring-like structure, which is just a ring, not a tunnel, this machine is a CT scanner, right? This is a CT scanner. Now let us see some of these images now. Now please see these images, right? Now if the cortical bone is white, it is CT. If the cortical bone is white, it is a CT. If the cortical bone is white, it is a CT. So the easiest way to differentiate a CT from an MRI is to look at a cortical bone. If it is white, it is CT. If it is black, it is MR. Now this is a transfer section, this is a coronal section, and this is a sagittal section. Never ever forget, in a transfer section, this side will be anterior, this side will be posterior, this side will be right, and this side will be left. My dear friend Dr. Ashwani is also looking at it. So please remember, if you look at an anatomy structure and an anatomy image, you might see an upside down image, but in the radiology, this is how the transfer section will be projected. Like a coronal image will be projected as a mirror image. What is a mirror image? That this side will be right, this side will be left, and obviously this will be superior and this will be inferior. Whereas a sagittal section, this will be superior, this will be inferior, this will be anterior, and this will be posterior, right? So always remember this very simple point. All right. Now who will tell me image number 1, image number 2, which one is CT? Which one is CT? So cortical bone is white, and that is why always remember, if the cortical bone is white, it is CT. So both are CT. But what I want is to look at the aorta in these two images. Always compare aorta with the muscle. If the vessel and muscle are of same color, it's a non-contrast CT. If the vessel is whiter than the muscle, then it's a contrast enhanced CT. If the vessel and muscle are of same color, it's a non-contrast CT. If the vessel is white than the muscle, then it's a contrast enhanced CT. But this is which contrast? This is IV contrast or an intravenous contrast, right? Intravenous contrast, correct? Now on the other hand, see these images. See the bowel loops here and see the bowel loops here, right? If the bowel loops are white, that means oral contrast is given. So you also may need to identify whether it's an IV contrast that is given or whether it's an oral contrast that is given, or an IV or oral, both contrasts are given. The vessel is compared with the muscle for IV contrast and the bowel loop is compared with the muscle for an oral contrast, right? Now if you another see a table with a rounded machine which is not a ring but like a tunnel, then this is an MRI. This is an MRI machine. So CT is a ring, MRI is a cylinder. Now let us see these two images. What do we see? Don't confuse this area. This is scalp. This area is bone. And if the cortical bone is black, this is an MRI. If the cortical bone is black, then this imaging has to be an MRI, right? Now on MRI, always remember WW2. What is WW2? World War II. What is World War II? Water is white on T2. Water is white on T2. No structure can be more white than water on a T2 weighted MRI. Water is virtually hyperintense to everything on a T2 weighted MRI, right? So look at the CSF here. Look at the CSF here. So this is a T1 weighted MRI and this is a T2 weighted MRI. The first image is a T1 weighted MRI and the second image is a T2 weighted MRI. Water is white on T2. It is to be noted that T1 weighted images are done to study anatomy, T2 weighted images are done to study pathology. T1 for anatomy and T2 for pathology. How to remember that? In the first prof you read anatomy, in the second prof you read pathology. So T1 for anatomy and T2 for pathology, right? Okay. If you see blur images like this, always remember then these images will represent nuclear scan. And the images of the nuclear scan can be easily identified by looking at the black spots. If you see the black spot in the brain, this is a PET scan. If you see it in the bones, this is a bone scan. And if you see it in thyroid, then this is a thyroid scan, right? So PET scan, bone scan and thyroid scan. Now who will tell me what is the name of this investigation? I am looking at it. Tell me. You have 30 seconds to tell me what is the name of this scan. Where are you seeing the black spots? Where are you seeing the black spots? So you are seeing the black spot correctly. Yes, you are seeing it in the liver and in the gallbladder. And if you are seeing in the liver and the gallbladder, this scan will become a HIDA scan, right? So this is a HIDA scan. So a very commonly asked question in the exam, and the examiner will give you any of this image and we're going to ask you what is the name of these investigations. This should be on your tips, right? Now, nuclear scans are very good, but they have got very bad resolution. So improve their resolution by nowadays combining a CT with a PET scan, and this investigation is called as PET CT. So nowadays, the standard investigation that we do in our day-to-day practice is not a PET but a PET CT, right? Okay, so this is some few points about how various investigations are seen. Now, let us see some of the diseases which are straightforward questions in the paper. Now, if you see this image, which is a standard part of your paper, I have not seen any paper when this image is not gonna be there. You see a biconvex hematoma, right? A biconvex hyperdense hematoma. What is your answer? Your answer is acute EDH. Acute EDH. And what is the most common vessel involved? Middle meningeal artery. Middle meningeal artery. Whereas this hematoma is surrounded by the brain. So this is intraparenchymal hematoma, right? This is intraparenchymal hematoma. Please remember, it's a revision going on. If you are unable to recall it, you have to open up your notes and you have to remember the entire topic of the head trauma, right? It's a quick revision that we are doing. When you see tiny hemorrhagic foci, where? At the gray white matter junction. Tiny hemorrhagic foci at the gray white matter junction. This is diffuse axonal injury. Diffuse axonal injury. Who will tell me most common NCCT appearance of diffuse axonal injury? Most common NCCT appearance of a diffuse axonal injury? Normal CT. In 80% of the patient with diffuse axonal injury, CT is normal, right? Now tell me, what is the shape of the hematoma here? It's a crescent shape. Yeah, crescent. What do we call it as? We call it as a banana shape hemorrhage. A crescent shape or a banana shape hemorrhage. This is seen in SDH, and because it is hyperdense, it is acute SDH. On the other hand, this hemorrhage is again banana shape, but it is hypodense. Hypodense crescent shape hemorrhage is chronic SDH. Is chronic SDH. And what about this? What about this? Subacute SDH. Subacute SDH. Subacute subdural hemorrhage. Right? Okay. Now, when you see hemorrhage going into the sulcal spaces, basically in any CSF space, what have we learned in the class? What are the common examples of the name of the CSF spaces? Cistern, ventricles, sulci, fissure. When you see hemorrhage in any of these spaces, what is your answer? Your answer is subarachnoid hemorrhage. Subarachnoid hemorrhage, which could be traumatic, which could be atraumatic. Now, who will tell me what is the most common cause of atraumatic subarachnoid hemorrhage? Most common cause of atraumatic subarachnoid hemorrhage. What is your answer? Rupture of Berry aneurysm. Rupture of Berry aneurysm is the most common cause of atraumatic subarachnoid hemorrhage, right? Okay. Now, hemorrhage, brain hemorrhage is a standard part of our paper, and you're gonna see one topic and one question on this particular point. Now, the second important image is stroke. This was a last year FMG screening exam question. A 65-year-old patient presented to the emergency. Just give me a sec. A 65-year-old patient presented to the emergency with inability to move his right side of the body. This CT was done, NCCT was done. Tell me, what should not be done in the management of the patient? What are we seeing? In any patient with stroke, what is the first investigation that we do? NCCT. And if you see a hemorrhage, thrombolysis is contraindicated. If you see a hemorrhage, thrombolysis is contraindicated. So that's a classical image of intraparenchymal hemorrhage. Whereas what is this? Sir, this is white, this is white. So are the both hemorrhage? What is the rule? CT पे white है तो क्या है? Hemorrhage है. If it is white on MRI, what is it? It is ischemia. If it is white on the CT, it is hemorrhage. If it is white on MR, it is ischemia. So that is ischemia. So why do we need to do an MRI on ischemia? Because in early stroke in less than 6 hours, NCCT is normal. NCCT is normal. Now let us see two more images now. Now I have a patient whose two images are done. This is done within 6 hours of left-sided hemiparesis, and this is done after 6 hours of left-sided hemiparesis. Now see the image here. This area looks nearly normal, whereas what is happening to this area? This area is appearing hypodense. So what is the finding of ischemic stroke on CT? Normal in the first 6 hours, and after 6 hours this become hypodense. Normal in the first 6 hours, after 6 hours this will become hypodense, right? All right. Now a calcification pattern is a very common thing that is asked in the exam. So for our quick revision, all the calcification patterns have been placed at one area. Can we quickly write them down? Periventricular pattern. This is called as periventricular pattern, and a periventricular pattern is seen in CMV infection. Diffuse nodular pattern. Diffuse nodular pattern is seen in toxoplasmosis. Periventricular pattern, CMV infection, diffuse nodular pattern, toxoplasmosis. Bracket pattern. Now this is in the shape of a bracket, right? Bracket pattern. Bracket pattern is seen in corpus callosal lipoma. Corpus callosal lipoma. Small calcification. This is called as subependymal calcific nodules. Subependymal calcific nodules are seen in tuberous sclerosis. And what is this? This is called as starry sky pattern. Starry sky pattern is seen in neurocysticercosis. Neurocysticercosis. And the last, but when you see the pattern along the gyri, I would like to call it as a gyral pattern. And a gyral pattern is also called as tram track pattern. And a tram track pattern is seen in Sturge-Weber syndrome. A tram track pattern is seen in Sturge-Weber syndrome, right? So calcification pattern in the brain. Now let us see a very important thing, and that is shape of skull. If you see this, what is this called as? This is called as hair on end appearance. And hair on end appearance is a feature of thalassemia. Thalassemia. Punched out lytic lesion. Punched out lytic lesion is seen in multiple myeloma. Multiple myeloma. Whereas salt and pepper appearance. Salt and pepper appearance is seen in hyperparathyroidism, whereas cotton wool skull, see this is cotton wool skull. Cotton wool skull is seen in Paget's disease. Now this is called as geographic lytic lesion. Geographic lytic lesion with beveled edges. This is seen in eosinophilic granuloma. Geographic lytic lesion with beveled edges is seen in eosinophilic granuloma, and the final is silver beaten appearance of raised ICT. Silver beaten appearance of raised intracranial tension, right? So very commonly asked points from the brain. Now in the normal chest x-ray, the first thing that you need to learn is how to count the ribs. So first, do not forget, this part of the rib that is reaching up to the midline is which end of the rib? This is the posterior end of the rib, right? And all these parts of the rib which are not able to reach up to the midline, these are which part? These are anterior end, right? So any part that is reaching up to the midline is posterior end. Any part that is not able to reach up to the midline is anterior end. So who will tell me? I am marking it. I am marking this rib as 1 and I am marking this part of the rib as 2. Tell me which one is anterior end, which one is posterior end. Which one is anterior end, which one is posterior end? Sir, this is reaching up to the midline, so this is the posterior end. I can't see this going up to the midline, so this is anterior end, right? And then do not forget, try to trace it from the top. The first rib and the second rib posterior end tends to overlap. The first and the second rib tends to overlap. So you have to be aware of that how to count the rib, anterior end of the rib and the posterior end of the rib, right? Now, some common x-rays that are expected from you that should be on your tips once you're going to write the exam. So when you see a blunting of the CP angle, the first answer that should come to your mind is pleural effusion, right? Pleural effusion. Just give me a sec. Just give me 10 seconds. Yeah. So when you see the blunting of the CP angle, this is pleural effusion and this is a right-sided pleural effusion. Similarly, you see a right-sided pleural effusion, right? Whereas on this side, I'm going to see a left-sided pleural effusion. So normally, when you take an erect X-ray, all the fluid goes down and you see the blunting of the CP angle. However, when the fluid is less, then the lateral CP angle doesn't get blunted. And in that cases, I have to tilt the patient like this. And when I tilt the patient like this, then the fluid goes along the lateral chest wall. So if you see fluid going along the lateral chest wall, then remember, then this is not a erect view. Rather, this is a lateral decubitus view. This is a lateral decubitus view. And the point that I want everybody to remember is what is the minimum amount of fluid that can be seen on a lateral decubitus view. Minimum amount of fluid that can be seen on a lateral decubitus view is 10 to 15 ml. Whereas more than 150 ml of the fluid is required to cause blunting of CP angle on a chest X-ray. More than 150 ml of the fluid is required to cause blunting of CP angle on a erect chest X-ray, right? Okay. Now those were pleural effusion. If you see air in the pleural cavity, remember, if you see air in the pleural cavity, then this is pneumothorax. If you see fluid in the pleural cavity, that is pleural effusion. If you see air in the pleural cavity, that is pneumothorax. So how do you know air is present in the pleural cavity or is present in the lung? If you see blood vessel traversing through the air, then the air is present in the lung. If you don't see blood vessel traversing through the air, then the air is present in the pleura. So tell me, what is this? Correct. This is pneumothorax again. However, what is happening here? In this case, there is so much of the air that it is pushing the trachea towards the other side. And since it is pushing the trachea towards the other side, this becomes tension pneumothorax. Tension pneumothorax, right? So either a pleural effusion or a pneumothorax or a tension pneumothorax is going to be there in the paper. Now who will tell what is this? I am giving you 30 seconds. Tell me, what do we think the diagnosis of this particular image? What do we see? Do we see air or do we see fluid or what? What do we see in this image? I can see air as well as fluid. I am seeing both. And since I am seeing both, what is this? This will become hydropneumothorax. This image will become hydropneumothorax, right? Hydropneumothorax. Let me just open my scan. Yeah. So this is hydropneumothorax, correct. Now, hydropneumothorax, pneumothorax, all can be very well seen on X-ray. However, in the sick patient, sometime we need to do an ultrasound, and this is a potential question in the exam. Always remember, on ultrasound, normally if you do an ultrasound of the thorax, you see straight line in the anterior part and a grainy appearance in the posterior part, and this sign is called as seashore sign, which is a normal appearance. However, what happens in pneumothorax? You just see some straight line, and this sign is called as barcode sign. So don't forget that a seashore sign is a sign of pneumothorax, is a sign which is normal, and a barcode sign is a sign of pneumothorax, right? Okay. Now what do we see here? When you see an opacity which is ill-defined and it is seen in bilateral central part of the lung, which is called as bilateral perihilar consolidation. A bilateral perihilar consolidation has been given a name. What is this called as? This is called as bat wing appearance. And if it's a bat wing appearance, what do you know from your class? This is a feature of pulmonary edema. A bat wing appearance is a feature of pulmonary edema, right? Now let's see what is this. So before we go on to the disease, let us do one thing. First, let us try to learn what are the various anatomical structures that are seen in this image. So this is a CT scan of the chest. This side will be anterior, this side will be posterior, this side will be right, and this side will be left, right? I can see these two black areas. So that means I am below the carina, and if I am below the carina, this will be right bronchus, this will be left bronchus. If I am below the carina, if I am below the carina, that means this white structure should be ascending aorta, right? And if this structure is ascending aorta, this structure has to be descending aorta. This is ascending aorta, this is descending aorta, right? And this structure is pulmonary trunk. This is ascending aorta, this is descending aorta, this is pulmonary trunk, and now I am seeing a filling defect within the pulmonary artery, right? Pulmonary artery. So this is an image of a pulmonary embolism. A very classical image of a pulmonary embolism. Examiner can ask you some normal structure as well as a disease. Whereas what is happening here? Now we have just learned this is ascending aorta, this is descending aorta, and I can see a flap within the descending aorta. So that means this is a case of what? This is a case of aortic dissection. This is a case of aortic dissection. And who will tell me which type of aortic dissection is this? Which type of aortic dissection? Ascending aorta is not involved. This makes it type B. If the ascending aorta is involved, this will make it type A. If it is type B, treatment is control of blood pressure. If it is type A, treatment is urgent surgery. If it is type B, the treatment is control of the blood pressure. If it is type A, the treatment is urgent surgery. So that is how you're going to differentiate them, right? Now who will tell me what is this? Again, a very commonly asked image in our exam. I am seeing a chest X-ray and I am seeing small nodules which are typically less than 5 mm in size. They are bilateral, they are diffuse. What is this? These are called as miliary nodules. Bilateral diffuse nodules is miliary nodule. Classical example of a miliary nodule which suggests hematogenous dissemination of the disease. Presence of a miliary nodule is a sign of hematogenous dissemination of the disease. Always remember that whenever you see these images, there will be a backup history. Don't miss this. The classical history will be PUO, pyrexia of unknown origin, or a low-grade fever, or a weight loss, and then you should think about an infection leading to miliary nodule, right? Rather than thinking it up as a money bag appearance or so on, right? Okay. Now, shape of the heart is a standard part that they ask. If they ask this is called as egg on a string appearance. An egg on a string appearance is a feature of transposition of great vessels. Whereas if they show you this, this is called as boot shape heart, which is seen in top. It is also a good idea to look at the history because egg on a string appearance, the classically patient will be less than 1 week old. And usually it is around 6 months to 1 year. That's a standard age of presentation for the top, whereas TGA will present within first week of the life, right? If the shape is this is called as figure of 8 or a snowman shape heart, which is seen in total anomalous pulmonary venous connection, whereas box shape heart will be seen in Epstein anomaly. And a box shape heart will be seen in Epstein anomaly, right? Now let us see some of the images of barium. If you see this very typical appearance, which is called as what? This is called as bird beak appearance, which is a feature of achalasia. Always remember, never forget to look at the history of dysphagia, which will be more marked for liquid. More marked for liquid, right? Okay. Whereas if you see this appearance, which is called as rat tail appearance, dysphagia will be more marked for solid. Think of cancer. Think of cancer. Now, cancer can also have a marked irregularity with narrowing and proximal shouldering, which is called as what? Which is called as apple core appearance. Apple core appearance or rat tail appearance, both are feature of cancer, right? Whereas this is called as corkscrew esophagus. Corkscrew is a feature of diffuse esophageal spasm. And if you see that the stomach is pulled up into the thorax and the G junction has also moved up, this is what is called as sliding form of hiatal hernia. A sliding form of hiatal hernia, right? Now this is the commonest image that we get in the exam. What is this called as? One part of the bowel is turned on its axis. What is this called as? This is called as coffee bean appearance. Coffee bean appearance is a feature of sigmoid volvulus. Whereas multiple contrast filled out pouching in the sigmoid colon is sawtooth appearance, which is a feature of diverticulosis. And what is this? A single contrast filled out pouching in the neck region. This is Zenker's diverticulum. Right? A classical image of a Zenker's diverticulum. What is this? Now what do you see? We are seeing large bowel and I don't see any hostrae. This is called as ahostral colon. Ahostral colon, which is a feature of ulcerative colitis. Ahostral colon is a feature of ulcerative colitis, right? Okay. Now this is a very standard image that we get in the exam. What do you see? I can see air below the left hemidiaphragm. Always remember, whenever I see air below the left hemidiaphragm, I do not know is it normal or abnormal. But air below the right hemidiaphragm is always abnormal. So what is this? This is pneumoperitoneum. This image is pneumoperitoneum. Air below the right hemidiaphragm is pneumoperitoneum. And the most common cause is the hollow viscous perforation. Whereas if you see multiple air fluid level, please remember it's a sign of small bowel obstruction. Single bubble, if you see single bubble, it is hypertrophic pyloric stenosis. If you see double bubble, it's a sign of duodenal atresia. If you see triple bubble, then it's a sign of jejunal atresia. However, multiple bubble appearance is a sign of small bowel obstruction. It's a sign of small bowel obstruction. What is this? One bubble, another bubble. What is this? This is double bubble appearance, which is duodenal atresia, right? And what is this? I can see the right hemidiaphragm, but I don't see the left hemidiaphragm. and I can see bowel loops have herniated into the thorax and they have displaced the heart towards the opposite side. So this is a classical appearance of CDH, congenital diaphragmatic hernia. Congenital diaphragmatic hernia, and this has been called as Bogue-Dalek hernia. Congenital diaphragmatic hernia, also called as Bogue-Dalek hernia, right? Shape of heart we have done, shape of skull we have done, and the next list is shape of vertebrae. Now this is bullet shaped vertebrae. Bullet. And a bullet shaped vertebrae have been described in achondroplasia. Right? Whereas, what is this? This is fish mouth. Fish mouth. Fish mouth is seen in osteoporosis. What is this? This is H-shaped vertebra. H shape is seen in sickle cell anemia. H shape is seen in sickle cell anemia. And what is this? This is picture frame. Picture frame is present in Paget's disease. Now, this is very easy. What is this? This is called as Rugger Jersey spine. Rugger Jersey spine is seen in renal osteodystrophy. And when you see one vertebra which has become very, very white, this is called as ivory vertebra. Ivory is also seen in Paget's. Ivory vertebra is also seen in Paget's. Whereas if one vertebra is collapsed, what is called as vertebra plana, this is seen in eosinophilic granuloma. And this is your easiest one. What is this called as? This is called as bamboo spine, which is a feature of ankylosing spondylitis. A bamboo spine is a feature of ankylosing spondylitis, right? Now, similar to that, you should also know some of the abnormal appearances of IVP. If the two kidneys are joined in the middle line, what do you call them? Horseshoe kidney. If the terminal end of the ureter is dilated, what is this called as? This is called as adder head. Adder head is a feature of ureterocele. Is a feature of ureterocele. When you see one kidney on one side and two ureters on the other side, this will be called as duplicated system. Right? Duplicated system. Whereas, on the other hand, if you see both the kidneys or on one side, this is called as crossed ectopic kidney. Crossed ectopic kidney. Right? Okay. In RGU, normally we see penile urethra and the bulbar urethra is bigger in caliber in comparison to the penile urethra. If it become narrowed, this is a classical image of bulbar urethral stricture. Bulbar urethral stricture, which is secondary to a bicycle or a straddle injury. Right? What are these? Examiner, as I've already told you, these are abnormal images. So examiner will write you what is the name of the investigation. All of them are MCUs. So if the shape of the bladder becomes like this shape is called as Christmas tree bladder. And if it's a Christmas tree bladder, this is a neurogenic bladder. Whereas posterior urethra is dilated here, and this is how the bladder look like. This has been called as keyhole appearance. And a keyhole appearance is a feature of posterior urethral valve. And last, if an MCU looks like an IVP, remember this, very, very simple cheat code. If an MCU looks like an IVP, this is VUR. Vesico-ureteric reflux. Question says it's an MCU and you feel that it is an IVP. That means this is a vesico-ureteric reflux. The dye has a reflux into the ureter. Right? So these are very, very standard images. I have deliberately kept it very, very short because the exam is very, very close and you are already stressed with the bigger subjects that are there. So I wanted you to show some very commonly asked images which are frequently repeated so that none of them are missed in the exam. Always remember, we should never be bothered about few odd questions that are there in the paper that you have never covered. We should always be bothered about those questions which are commonly asked in the exam that you have read multiple times during your preparation, because those are sufficient which can help you in passing the exam, right? These are some of the tables. I mean, there is no rocket science into this. It's a pure factual tables. Please make sure that you revise them once you're gonna go for the exam. These are the values for various radiological procedures and the dose that has been given in them. These are the radiation limit for various categories: for the patient, for an occupational worker, for a pregnant patient, or for a pregnant occupational worker. I'm going to share all of them on my Insta page also in a form of a post, or I will share this PDF on my Telegram group also, as well as on your group also, right? Okay. Now this is a very important device. This is called as TLD, and TLD stands for thermoluminescent dosimeter. It's a radiation monitoring device which, as a radiation worker, I use, and this is a symbol of a radiation hazard. All right. Okay. Few more tables. Radio sensitivity: which cell is most sensitive, which organ is most sensitive, which blood cell is most sensitive. This should be known to you without a doubt. And this is the last list in this section. Radio sensitivity of the tumor. The highly sensitive tumor, always remember it with a mnemonic Wilms. W for Wilms, I or E for Ewing's, L for lymphoma, M for myeloma, and S for seminoma. Least I used to remember it with the mnemonic HOM. Hepatoma, osteosarcoma, melanoma, and pancreatic carcinoma. Rest all are intermediate, right? So these are very commonly asked points in the exam. Just make sure that you are aware of them. If you can remember this also, then that will be icing on the cake. Half-life of various radiological radioisotope: technetium 6 hours, 123 13 hours, 125 60 days, 131 8 days, 132 2.3 hours, phosphorus 32 14 days, cobalt 65.2 years, iridium 192 74 days. The best way to remember this is remember it one day before the exam and vomit it out in the exam. That's all. That's the best way, right? So that's all about the common, very common must know points. You people have worked very hard for the exam, and I'm telling you, it is not a difficult job to crack the FMG screening exam. Just make sure that whatever that you have read till now, you are revising it again and again. Now, these are my social media handles. This is my YouTube, this is my Insta, and this is my Telegram. I'm gonna share this PDF on the Telegram as well as on the DBMCI FMG groups also. So you can use any of them to get the access of this annotated PDF. I wish you all the best from the bottom of my heart, and I will pray from the Almighty that you all come out with flying colors and you all see pass in front of your name in the FMG exam coming ahead. May God bless you all and have a good night.